thank you for inviting me in. I see some of my fellow vampires from around the country here as well. I've been asked to provide the palliative care perspective, but I'm going to provide a palliative care perspective. And I think it will dovetail nicely with what's been said already this morning. There are some definite overlapping themes. This won't be a surprise to many of you, and I have abridged these, but these are the principles of palliative care. We should neither hasten nor prolong death. We alleviate symptoms, and we provide psychological support to patients, families, and staff, a lot of times around periods of transition. And this is from our National Palliative Care Strategy, which you'll see is from 2001, but I think still very relevant. So all people with life-limiting illness who could benefit from palliative care should have timely access to quality palliative care that's both culturally appropriate and provided in coordinated ways. And I really like this image from the World Health Organization because it actually encompasses a lot of the things that I want to say about palliative care, who it's for, who can deliver it, where it can be delivered, and some of the major benefits it has. And at the bottom right, you can see that it doesn't have to be delivered by palliative care specialist providers. I did a grand round at Hastings Hospital not long ago, and I had a kind of Oprah moment where I looked around the audience and there were people there from all sorts of different backgrounds, and I said, "You do palliative care, and you do palliative care." And everyone went, "Oh, I suppose I do, really." And this is also to illustrate from the World Health Organization that palliative care is not just about cancer. It used to be a long time ago, but now the majority of patients who come to us either have cancer and a non-cancer illness, or their primary problem is a non-malignant illness. So who benefits from our principles? Anyone with a life-limiting illness, anyone with significant symptoms, and in any situation where there's mismatch of expectations about goals of care and treatment, which probably encompasses most people in acute hospitals. So to further illustrate that end-of-life care is provided by others, we did a snapshot audit of Hawke's Bay Hospital September. There were 31 deaths in hospital, and only 17 of them were known to the hospital palliative care team. So there are lots of other people providing end-of-life care around the place. After rapid response team calls, I do apologise for my TLAs, there are quite a few of them, I'm sorry. After rapid response team calls, studies have shown that there can be up to a 6-fold increase in palliative care referrals, which is fairly significant for us. So what we don't want to encourage necessarily, until we have resources to match it, is everyone phoning 0800 palliative care. I see that the Goals of Care project requires and supports improved health literacy and also death literacy in the general population, but also in clinicians. I think we can't succeed without that. So some of the challenges for Goals of Care, which we've heard some about this morning, acknowledging that the person has a life-limiting condition, and some of the reluctance around that can be within the patient and the family, but also within the primary clinicians. Diagnosing dying is notoriously difficult. It sounds really simple, but actually it's not. And we've heard from Alex that oftentimes treatment is both offered and given, which is not wanted or warranted, and that is described as futile and burdensome, which are quite emotional words, I think. And conversations are often deferred due to lack of time or training, and sometimes downright avoided. So let's bring it back to some things that we know for sure. Alex has alluded to some of the evidence this morning. We know that even just being admitted to hospital takes a toll on physical health. If you're frail when you come into hospital, you're definitely going to be frail, if not worse, when you leave hospital. Deconditioning is a real problem. I learnt the phrase pajama paralysis recently, which I think is quite, it's funny and also sad, I think. We know that critical care survivors suffer mental and physical ill effects of their stay in critical care, and family members of survivors and also people who die suffer mental health consequences, and that's a significant problem. We know from studies that have been done in New Zealand, Australia, the UK, and around the world, that 1 in 5 inpatients in acute hospitals have a palliative care need. And this is sometimes not recognised, and if it is recognised, it's not documented. And if it is documented, sometimes patients aren't referred, and sometimes, even if it's recognised, the need is not acted upon. So spiritual needs aren't addressed, preemptive prescribing doesn't occur. So recognition is only part of the problem. And again, I think that's probably from one of Alex's papers. Rapid response teams detect deteriorating patients and also dying patients. It's hard to tell the difference between the two. Thinking about communication, we've heard this morning that communication problems cause a number of issues and adverse events to be reported, and they also result in the following list of really unpleasant consequences for patients and families and clinicians. And when I say resource-patient mismatch, that's really about unwanted and unwarranted treatment being given to one group of patients, which diverts resources from people who could benefit from it. And deteriorating dying patients look the same. This is paraphrased from Te Ara Whakapiri, which is the section called Recognising the Dying Patient. And any of you who've been to a rapid response call will know that patients often have an altered conscious state. They often have cardiovascular instability and perfusion changes, along with respiratory changes. And 1 in 4 of them will identify end-of-life needs. So what else do we know for sure? We know that palliative care can improve outcome. One of my favourite papers showed that in patients, I won't describe the entire paper because it would take too long, but basically palliative care in this particular context made you live longer, happier and more comfortably than standard oncology care. And I love that paper. Palliative care can reduce the number of intensive care admissions, can reduce intensive care length of stay, and can reduce hospital costs, which, as Alex said this morning, is not our main focus, and we may be accused of focusing on that, but it's definitely a pleasant side effect. We also know that other non-specialist palliative care physicians can, of course, have the same effect: improving symptom control, reducing ICU admissions, reducing ICU length of stay. So there are always challenges for palliative care, and these are just a small number of them. So what we already have is an increasing number of referrals to our services. And by the way, I'm talking about hospital palliative care, not community services, although I recognise that many teams provide both and there's significant overlap, because after all, we're looking after the same patients anyway. Rapid response calls often occur after hours, and so there is a need there that is not able to be met by our current resource. We have an ageing population. One of my geriatrician colleagues tells me that by 2060, 3/4 of people dying in this country will be over the age of 65, which is quite an interesting thing to think about. As I mentioned, we've got wider applicability of palliative care into non-malignant disease or into undertaking of high-risk surgery. And we already have an existing shortfall of SMOs in New Zealand. So these are some significant challenges. And the patients that we're looking at are not just older, they're more complicated. I very wistfully remember my days as a house surgeon when a patient would come into hospital with a single problem and a single medication, or maybe 2. But those days are gone. Patients are much more complex. They're more frail. The acuity of patients we're looking after is much greater. You know, people are being discharged home who in the olden days would have been kept in hospital on the ward for longer periods of time. We know it's harder to diagnose dying in older patients. The diseases we're looking after have different illness trajectories, and the practice that we are working within, not just palliative care practice, but physicians, surgeons, oncologists, different treatments are giving rise to different life expectancies. And not only clinicians are less fatalistic, but patients are less fatalistic than they used to be. People want control over their illness. They want to be masters of their own fate. So thinking about some of the missed opportunities, why do these important conversations not occur? Because training and support are often absent from the clinical workplace, the time and timing of these conversations is really critical. The team who's having the conversation about whether it be a binary conversation, would you like resuscitation, would you not, or would you like to choose from my a la carte menu of intensive care activities, the team who are having that conversation have an incomplete understanding of the potential success and impact of those treatments. They may not be aware of the impact of critical care on a frail elderly person. We don't really have a framework that's consistent nationally to support this, and the wrong questions are often being asked. And the wrong question to me, and I'm sure we possibly have asked it ourselves, certainly overheard it being asked, do you want everything done? And I'll talk a little bit more about that in a minute. The other thing we need to consider is, what is a good outcome for this person? What is feasible, what is reasonable to expect from what we know about their frailty, their performance status, and their intercurrent illness? What is actually possible? And then, of course, we need to consider the individual preferences for treatment. So, this is from a really interesting paper by Timothy Quill, who is very well published in palliative care research. And the team looked at what everything might mean to patients. So it might mean, if I say, yes, I want everything done, it might mean, don't give up on me. I'm afraid that you'll abandon me. It might mean that I'm afraid of dying. It might mean that I don't really understand how sick I am. No one's really explained it to me in terms I can understand and make sense of. And for some people, they do value life above all else. I want all possible treatments, even if the chance of success is small. And I think Sarah mentioned this morning. You may understand that you have a life-limiting illness, but until you are in a particular situation, you can't necessarily predict how you might react. And people are allowed to change their minds. So what does everything mean to the team? So to the average RMO who's having a conversation in a busy ED with a patient who's very sick, everything often means everything that is technically possible, Alex's giant list of investigations and treatments and interventions, even if it's not going to succeed. Because it's quite rare that a person would have a conversation with a patient like this and not have an idea that survival was unlikely. In our heart of hearts, we know that things are not likely to succeed sometimes. And in most centres, everything means referral for multi-organ support in an intensive care or high dependency unit, or in fact in another centre. So when we consider any life-sustaining treatment, what we want to be able to do is to return that patient to a quality of life and level of function that's acceptable to them and consistent with their goals. Sometimes goals need to be modified. Sometimes they're just not achievable, but that's what we're aiming to do. But there are so many risks with life-sustaining treatment and interventions. Some of them are visible immediately and some not. Some are immediate and some delayed, like the PTSD we've heard about. But mostly the risks are really hard to predict. I don't know if anyone here has heard about the RUB, which is an abbreviation for the risk of unacceptable badness. And this is highly individual. So this is thinking about the physical and functional outcome of someone who survives a devastating illness. What kind of level of function would be acceptable to you as an outcome? And my two examples here, one of these examples is from the Atul Gawande book, Being Mortal. I'm sure some of you have read it, in which he describes talking to his own father, who was planned to have, I think, high spinal surgery with great risk of damaging the spinal cord irreparably. And he assumed, because his father was a surgeon, that he would want his non-negotiable outcome would be full independence. But what his father actually said shocked him. He said, well, as long as I can enjoy chocolate ice cream and watch football on TV, I don't mind if I'm fully dependent for my ADLs, which really surprised him. So, but for him, that's his ideal outcome. That's his tolerable survival. But for me, if I couldn't go swimming, I would not want to survive. I think we all have our different perspectives on functional acceptability. So it is very highly individual. I would encourage you to read the paper by Grant Gillette, who talks about the risk of unacceptable badness. I think it's from about 1996. It's quite old. So I'm coming to a conclusion. And in conclusion, it is complicated. This is not going to be easy. It's already complicated. End-of-life decisions are difficult. We don't all think the same way. We're never all going to agree on everything. It doesn't mean we're on the wrong track, though. And it doesn't mean that we shouldn't withhold or withdraw treatment if that's consistent with what patients want. Palliative care principles are part of core competencies for all practitioners. We know that the palliative care landscape is evolving, both in resources, in practice, and in demographics. Goals of care conversations are key, and they need training and support to be done successfully, and patient preference must be incorporated. So in an ideal world, it would be nice to imagine that all medical staff, and I include nursing staff and allied health in that also, including those who belong to rapid response or PAR teams, should have training in the recognition of and communication with patients who have a palliative care need, and that hospital palliative care teams should be sufficiently resourced to consistently provide advice and support to teams as needed. And goals of care conversations are standard of care. Thank you.